Doctor, I need your help. The patient at 7:30, they're not responsive. Can you come take a look?
Sure, sure.
Lonnie, this ain't his day job.
What can you tell me about this patient?
He had some sort of ENT surgery. I'm not sure, but I just found him like that.
Okay. There's a pulse. He's not breathing. Call an airway emergency.
Yes, doctor. Doctor, I don't see chest rise. The saturation's dropping. 70%, 65, 50%. I don't see chest rise.
Quick, intubate the patient. I can't see any cords.
40%,
I can't get a clear view.
20%. Doctor, he's bradycardic.
I can't see anything.
I don't feel a pulse. Call a code.
In a patient with a tracheostomy, the tracheostomy tube is placed in the trachea, which can still connect to the throat and oral cavity, unless there is a blockage above the tube, such as a tumor or swelling. In a laryngectomy, the airway is physically separated from the throat and oral cavity, so it is impossible to ototracheally intubate somebody with a laryngectomy. In both cases, placing a tube directly into their trachea through their neck should obtain access to the airway. This is easier to do in a patient with a laryngectomy. Laryngectomy is going to be in the center of the neck. You can see it has a deep hole. If you look down the hole, you can see into the trachea, visualizing the tracheal rings. The skin transitions directly to the pink tracheal mucosa without any intervening granulation tissue. The patient may also have an incision going across the neck. This is a tracheostomy. Here is the flange of the tracheostomy. You can see it from the side.
So when I found him, he wasn't breathing.
Okay. There's a pulse. He's not breathing. Call an airway emergency.
This patient had a laryngectomy, and he's going to need positive pressure ventilation, but he can't be intubated through his mouth. We're going to have to put the tube into his trachea. I see chest rise. His O2 sat is coming up. 70%, 80%. I think he's going to be okay.